I'm going to talk a little bit about surgery, and actually it really dovetails very well with Paulo's.
Just click that forward.
You see all the names here of all the people that have helped. Every time I talk about this data, I always talk about all the people that helped. And this is, again, just to dispel the myth that there's such a thing as sensory and motor nystagmus. You can read this article if you like. But David Kogan himself, in a letter in 1974 to Bob Daroff, said, you know what, you're right, we shouldn't use the term sensory and motor nystagmus anymore. In 1974, the guy who invented the terms said don't use them anymore, and they're still in textbooks. So I don't know what more we need to do.
Click in.
Yeah. So David went over CMAS. That's the classification system that I use to try and understand this. These are the CMAS nystagmus types. The ones we're talking about this morning are the three you see on the right: infantile, fusion maldevelopment, and occasionally spasmus nutans. So I have a photo up here, usually of a kid with a head posture. This is the clinical null position, NP. This is the mathematical formula.
Let me show you something.
Oh,
Something cool here. If you go this, you can now point. And
Oh,
drag.
cool.
Yeah.
Oh, that's what I was
nice. So this is the clinical null position up here. These are all of the influencing factors on the head position. And this is their expression in a formula which we put together for our PAN and APAN papers. This is why when you take a patient with a head posture and you just do static surgery on them, you don't always get the results you think you're going to get without any other evaluation, without evaluating all of these things. So the position of the head in space in relationship to the eyes in the orbit when a patient is looking are dependent on all of these factors. So if you're only in the room examining the patient for 30 seconds, you're never going to see this stuff. And that affects how the head position is turned. So I'm going to talk to you with how my classification of nystagmus surgical procedures, and there's really 9 of them. And this is the result of a consolidation of hundreds and hundreds, maybe approaching 1,000 procedures now, that what I've tried to do is make an algorithm that's easy for clinicians to follow to assist their patients. And it's based on a clinical evaluation. Interestingly, I've kind of excluded eye movement recordings from some of this because I wanted to make it easy for physicians around the world and around the country to be able to treat their patients before they incorporated all of the modern electrophysiological approaches. So the first one is very simple, and in 22% of the patients that I operate on, a standard Anderson-Kestenbaum procedure or a horizontal recess resect is performed on each eye, as David suggests, or Paulo suggests, and it's still about 1 out of 5 patients who have nystagmus surgery. Now, this is clinicians are missing this, and I don't understand why, but patients with albinism and other afferent system diseases, specifically retinal diseases, often present with chin up and chin down positions. We were just in China, and I saw 70 families, 65 of the kids had chin down positions. I mean, that's not just an association in China. It's something I see here as well. I don't know why this is ignored. I've talked to other people, and they think that this chin down posture is from photophobia or light sensitivity, and it's not, because if you record the patient, they have a null position and up gaze. So this is the second most common operation that I perform here in the hospital, and I combine inferior rectus recessions with superior rectus recessions with inferior oblique myectomies, and then I operate on 2 of the horizontal rectis, either tenotomy and reattachment alone, or I do recessions for strabismus, ESO or EXO. And this is performed second most common. Third most common is strabismus alone. So straight head, strabismus, and nystagmus. I just operate on all 4 horizontal recti, however you like. You can do a BMR recess with a BLR tenotomy for ESO, or you can do little bits of R&Rs, or you can do resects and tenotomy. However you want to combine the 4 horizontal recti to take care of only the strabismus will help the nystagmus. Interestingly enough, strabismus surgeons have been treating nystagmus unknowingly for 160 years, or maybe longer. Depends on how far you go back. This is what Paulo talked about before, which is a really excellent approach to the treatment of nystagmus, strabismus, and anomalous head posture. Basically, you straighten the head with the fixing eye, and then you straighten the eyes with the non-fixing eye. That's the simple way to do this. So you place a prism over the fixing eye until the head straightens, and then you keep that prism up. You neutralize the other eye with another prism, either base in or base out, and then do R&Rs, recess and resects on both eyes to straighten the eyes, straighten the head, and change the nystagmus. Operation 5 and 10%. This is also very common after patients with some of the neurological diseases that Avery discussed before, especially patients with tonic gaze deficiencies associated with PVL and brainstem disease with demyelinating diseases. They'll often have chin down and chin up with tonic gaze deviations, and they present like this with chin up positions. In this situation, I do the obliques. Yes, I get rid of them. I do bilateral superior oblique tenectomies, 5 millimeter nasal to the superior rectus, and I treat that with inferior rectus recessions. The reason I don't do vertical R&Rs, recess resects, for chin up and chin downs is because that creates more cyclotorsion and alphabet patterns unless you transpose the tendons. And how much to transpose them, I don't know. A tendon width, this has been written about, especially in the restrictive strabismic literature. So by doing the oblique and the inferior rectus, I've taken care of creating comitants across horizontal gaze, both superior oblique and inferior rectus for chin up, and inferior oblique and superior rectus with chin down. And I've done dozens and dozens of these. Now, all of these patients, every single patient I've operated on for nystagmus, generally has about a 20% chance of needing another eye muscle surgery, similar to strabismus, for something, a new strabismic deviation, a new or recurrent head posture. And I believe that a lot of the patients that require second procedures, especially for strabismus, are the result of innately poor fusion in addition to the nystagmus. If you have a patient with good fusion, you can do a lot on their eye muscles and get away with it. Operation number 6, which is tenotomy and reattachment alone, only 9% or less than 1 in 10 patients have only nystagmus with no anomalous head posture, no strabismus, or no convergence damping. Operation number 7, which is a multiplanar head posture where they're over, tilted, and down. What you could do is similar to what Paulo had presented, is in addition to doing an R&R, if you vertically transpose the horizontal muscles, then you can also take care of the tilt as well. So I do a 1 tendon with transposition. And there's a little trick for all you surgeons. If you grab the pole of the muscle that you're moving it from, and you grab the pole of the muscle you're moving it towards, and those two locking forceps are now on the spiral of Talot. And now you can use those two locking forceps as your new insertion site. And that works better than all of the measurements because you've kept your locking forceps showing you the spiral of Talot. That's in press. And then last operation is, we have 2 more. Operation 8 is vergence damping. This, as Lou suggests, is the most powerful treatment for infantile nystagmus. If a patient is binocular, exhibits stereo, adapts to basal prism, fast prism adaptation in the office, with or without a -50 or -1 over the top, then a BMR recess with or without lateral tenotomies is the most powerful operation for nystagmus. And about 6% of the patients are eligible for this. And 5% have a torsional alone. And I do and I just kind of borrowed this technique and reproduce von Norden's description, which is a horizontal displacement of the vertical recti 1 tendon width. Again, I grab the poles of the muscle I came from and the muscle I'm going to and use those as the new insertion. So this is my surgical approach, and I almost do these 9 operations in this percentage till to this day. So I do 3 to 5 of these operations a week, and they follow this pretty much this protocol. So this algorithm can work for you too if you want to operate for patients with nystagmus, with the caveat that we're not curing anything. It's important to communicate with the patients. Nystagmus, as far as I'm aware of, is not a curable disease. It's only treatable. So the problems as a result of the nystagmus will still be there after the treatment. It's just that everything may be a little bit better. And that's part of the important communications that we have with our patients and our families. So that's my quick whirlwind tour of nystagmus surgery. But I think it gives you a good idea about how clinicians and Paulo's in another part of the world and I kind of think the same way about an algorithmic approach to these treatment and employing nystagmus surgery. And it's not, I don't look at this, and it's my own personal perspective, as aggressive. I look at this as a standard procedure. We've been operating on the eye muscles for 160 years. We have these skills, all of us that do this. To apply them to this patient population, for me, is almost a slam dunk.
That was fantastic. I just want to remind everyone, you can hear all these talks again, especially that one, just by going to the archive, and you can watch it as many times as you want. We'll have all of these talks listed out. I want to ask if there's any comments from the other faculty before we move on to the case presentations about what Dr. Hertle said. Yeah, go ahead, Dr. Nuki.
Can I just, obviously, Rick, I stole a lot of your book, so I completely agree with your approach, except for one thing. When you treat, I'm a little bit, worried about treating children with the chin down position, because very often, in my experience, when you treat children with chin down position, you do not see this position is sometimes related to the strabismus itself, because the strabismus in this population is always often associated with the overaction of the inferior oblique, and the child often use this chin down position to minimize the angle. And I found one patient I treated for a chin down position, treating in the way that you described it, and it didn't work at all. Because I think that in chin down position, what you have to look for is the stereopsis, the normal binocular vision in these patients. Otherwise, you treat the patients and you do not offer them what they need, because the position is just related to the minimize the amount of strabismus. So you treat the patients with a VU condition, with a alphabetic attitude, with a VU, treating him as it was for nystagmus, and actually, you should look for binocular vision in these patients.
Yeah, I agree with you, Paolo, many aspects, but the largest population of patients with chin down are the patients with the least amount of fusion. That's the albino population, the patients with albinism.
Yeah.
They have no binocular function, so they're not using their head posture for strabismus at all, unless there's a postulation of a monocular straightening of the world in up gaze that's not present. But we record the nystagmus, and it's clear that there's an up gaze null. So I think in the patients with albinism, it seems to really make a huge difference. And we've reported the albino patients separately.
So the albino patients should be treated like this, but not other patients, because chin down position treated in the way that you do, can be not the best option. So in albino patients, I can agree with you, because you have certainly a type of nystagmus that could obtain a good result. But otherwise, I'm not going to treat other patients with the vertical surgery.
Sure.
And the second thing is that I'm not doing any more myectomy. I must be sure about the position of the inferior oblique. If you detach the inferior oblique, when you cut the inferior oblique remains there. It's not like the medial rectus, the superior rectus. The inferior oblique remains there, and the position of the attachment after a myectomy, in my experience, is not the intended one. Often the position of the inferior oblique goes, quite chaotically. So I'm just doing recession in all these patients.
Sure. Great.
All right.
Rich, I'd also like to make a plug for doing bilateral oblique surgery in patients with an oblique null, with a tilted null. This spares the vertical recti, and this has been in the literature for decades. And my last two cases, I just followed Luda's recipe perfectly, and it's a very good recipe, and it's faster than doing 4 muscle surgeries, and in my SOFA n equals 2, it's terrific.
Sure, I agree. I think that the key for me with oblique surgery has always been, and this is something from Marshall and way back, was that the attention to detail has to be incredible on both sides. Because I think that that's where you can mess up a lot more with the recti than you can with the obliques and create an unintended form of cyclotropia or cyclostrabismus. And so I think that if you want to approach the obliques, and I do all the time, I'd make sure that I do the same thing on both sides. Whatever I'm doing, I do exactly the same thing in the same way. I think it's very important.
All right, and then Dr. Cowell, you can go ahead and turn your camera on if you want to. And then Dr. Granite, we're going to start with your case. If you want to start, go ahead.